Hello, everyone. I'm Brian Hong from Taipei City Hospital.
Hello everyone, I'm Valista Nabima from Jianxin General Hospital in Taipei.
Today we have a big shot, Dr. Michael Bullard. I think some people will regard him as the founder of Taiwan emergency physician. And can you tell us about the history during his time?
I can tell you a bit. I wasn't the founder. I was the grandfather or the godfather.
The father. The father.
Yeah. So back in early 1980s, a colleague of mine from Canada, a neurosurgeon, was at Chang Gung Memorial Hospital, bringing in neurosurgery as a new specialty. He was training the next generation of neurosurgeons. And he noted that the emergency departments were a bit of a disaster, largely because the only doctors in the emergency departments were junior residents and medical students, right? So he contacted the superintendent of Chang Gung in 1989 when my wife and I were looking for an international experience. And they flew me over here for 4 days. I looked around Linkou, Taipei, and Geelong emergency departments. I made a number of notes. I had a one-page set of suggestions. And he said, okay, when can you start? So we negotiated back and forth about salary, and we came here in August of 1989 with my 1-year-old, my 4-year-old, and my wife just newly pregnant. So it was an auspicious start. During that first year, I was mostly spending time in the emergency department working with surgical residents because it was easier to teach skills than history taking with my language inability. And I managed to write a 300-page modular educational program for emergency medicine and also recruit my first 5 residents. So starting in the second year, I had 5 residents for a 2-year program. The next year we had another 5 for a 2-year program plus 2 for a 4-year program. And we built and built to, we had at least 50 residents in our program. But during that early time, one of the many things that I identified was that doctors and nurses didn't work together as much as they worked independently, side by side. And in emergency departments where you have a lot of seriously ill or seriously injured patients, you need a smooth running team so that everybody's doing what they need to do without waiting for someone else to tell them. So in my educational process, what I would do is I would build case-based scenarios, meaning the patient comes in, okay, what does this nurse do? What does this doctor do? What does this resident do? What does this consultant do? What does the respiratory tech do? And so I would write these like a 1-act or a 2-act or a 3-act play. And then I would get my residents to translate my work into Mandarin. I would also create slide sets with didactic teaching, also get those translated into Mandarin. And then for each of my 5 residents, they would have 4 of these topics. So it could be chest pain, could be multiple trauma, could be meningitis, could be hypothermia, any of those things. And they would first, at Linkou, take the necessary nurses based on my scenario, the necessary RTs, residents, etc., and train them in the play. Then we would play it twice at Linkou. Then we would go to Taipei Jijin, train them, repeat it there. Then go to Geelong Jijin, train the nurses, teach them there. So that at the end of 2 years, the relationship between my residents, now to become first emergency physicians was a strong relationship with the nurses. So the nurses were happy, the doctors were happy, and they were working as a team. So that was kind of the first step. But an important step along the way was, you know, Chairman Wong Yong-ching of Formosa Plastics. He was my boss. And every Sunday afternoon, he would have meetings in his penthouse at Formosa Plastics downtown, and would have the superintendent, medical superintendent Chang, administrative superintendent Chang, and the various chiefs, depending on, sometimes it would be all, sometimes it would be few. And a couple of times I was there, and the second time I was there with Dr. Liao, who was my partner in crime, and we worked extremely well together. Anyway, we were sitting in a big circle, and Chairman Wong has a big domed ceiling, and if you whisper here, you can hear it over there. No echo. It's kind of like a whispering telephone. Anyway, so he asked me what I thought of Chang Gung's emergency departments and how they were doing. And I said, well, Chairman Wong, you realize that we see about 17,000 outpatients a day at Chang Gung, and every outpatient clinic has an attending staff. In your emergency departments, where the sickest and the most injured patients come, no attending staff. So I would say emergency, not so good. So he turned to medical superintendent Jiang and said, well, first he said to me, you're right, that doesn't make sense. Then he said, we need attendings there starting next week. So Jiang said, okay. And Administrator Jiang, not so happy. How are we going to pay for this? Chairman Wong said, your problem. Figure it out. So they did. But this was good for me because it meant that junior doctors from GI, from endocrinology, from internal medicine, from general surgery, from orthopedics, were all stuck in emergency for 12-hour shifts, getting paid, but essentially doing nothing because they would only see patients that they considered were part of their specialty training. So administration were watching this, paying money, being very unhappy. So when my first residents graduated, the 5 of them, and started working, the administration said, "Ooh," because they're seeing all patients, doesn't matter what kind, they're working hard the whole shift, and all of a sudden they're seeing value for money. So every year we would train more residents. Every year fewer and fewer of the specialists would have to sit in emergency. So they were happy too because they got to go back to their department.
Right.
So the whole system, because of that one meeting with Chairman Wong, made the transition into emergency medicine in Chang Gung very smooth. Except the specialists, the old VSs, they weren't too happy and they would still attack us. Wasn't very clear why. They felt they were losing control, but control of what? If we admitted a patient, we didn't admit to us, we admitted to them. If we sent a patient to outpatients, we didn't send them to our outpatients. Initially, we sent them to them.
Exactly.
So they weren't losing control for anything, but they didn't understand it. So they would attack us. But I told you about Dr. Liao, my partner in crime, and he became the emergency department chief in Chang Gung. He built an IT system, an ED information system, programming in DOS language, very difficult. But I helped him build it by helping design the data fields and the information we wanted to capture, and he would use English words or Chinese words, whichever took up less space on the screen. And so we would capture time patient arrived, time of triage, time seen by nurse, time seen by doctor, time consult put in, time the consultant arrived, consulting service, time the consulting service decided whether to admit or not, time patient went to the ward, captured 3 presenting complaints for each patient, up to 3 diagnoses, etc. So all of this information we captured. We could then print out data tables, anything you wanted. So when a department attacked us and went to the superintendent and complained about our terrible care, we would have a meeting. The superintendent would call that chief and us to a table, and we would talk back and forth. And after a few minutes, we would bring out our tables, and you said you saw our patients within 2 hours. Actually, you can see it's 12 hours. You said you admit patients within 12 hours. Actually, it's 48 hours. So we would give the one package to the superintendent. We would have one, and we would give one to the dissenting chief. And in about 2 minutes, superintendent would say, you bring innuendo, they bring data, data wins, you're wrong, fix it. So they soon stopped attacking us. So that computer system protected us because it gave real information. In those early years, I mean, clearly it was important for me to, when I was brought to Chang Gung, the hospital just wanted me to train doctors for their emergency department. And I thought, well, that makes no sense. How can I train somebody without getting them a certificate, a specialty, accreditation, etc.? So I looked around the island for people with like-minded thoughts, realizing that the time for emergency medicine was here. And I found about 100 interested people, and within that, we, Dr. Liao and I, and many of the early leaders, we formed a group of about 20. And we went to the Society of Critical Care Medicine and talked to them and asked if they were interested in having emergency physicians and trauma surgeons join their group, which they did. And so we changed from the Society of Critical Care Medicine to the Society of Emergency Critical Care Medicine. And within that organization, we were able to elect the majority, not the majority, we elected 12 of the 20 board members from our group, which allowed us to have power within the board to pass things that we thought were important. And so one of the things that we knew was important was to create and have an exam ready by 1992, which is when the 3 Veterans Hospital residents and my first 5 residents were completed their training. So we needed a certification exam. So that was one thing we did within SECCM. The other thing that we did was create those accreditation standards that we wanted to pass on to Weisensu, because the current accreditation standards for emergency were quite weak, and when we asked for more equipment, the hospital said not needed. We said, yeah, needed. No. But once the new accreditation standards came in, then suddenly the hospital provided what we asked for. So that was the early years. The other thing is that the Society of Critical Care Medicine had a journal that they began in 1990. So there was a place for us to publish. And it wasn't until 1994 that TSEM was created specifically for emergency. But within the SECCM and then TSEM, we also started the road to improving, standardizing ACLS training. That was very important, because before I had arrived on the island, the way ACLS was taught was just by lectures. There's no hands-on practice for intubation, practice for CPR, focusing on megacode. You know what megacode is, where you do simulated cases and you have the students react. So we created a very good program. In fact, we created a program that serviced 120 students per course, which we needed the size in Taiwan because we had so many numbers. And so after, I won't tell you about the early failed years, but by the time we got Wei Sen Su to agree that all nurses and all doctors in emergency and ICU needed ACLS, we were ready to go. And I personally trained over 3,000 providers and 300 instructors. So about 1996 is when we put together the ACLS Joint Committee that included both TSEM, SECM, cardiology, and later anesthesia and pulmonary, I think, joined. But the idea was we didn't want different forms of ACLS being taught. We wanted one standardized thing. And again, back to sort of what I talked about with my scenario teaching, the key to ACLS is its teamwork.
Right.
So everything about many of these ED educational things like a CLS, a TLS, PALS, they all teach candidates how to work in a team, how to work effectively, and how to solve rapidly and in a standard way unstable patients of any age.
Yeah, and then so that's 1996, right? And then 97, we passed the law.
Yep. Well, 97 was the EMS
The
law.
act. The
The EMS Act,
Yeah.
right?
Yeah.
Yeah. Going back to the EMS, so we started back in probably 90 or 91. We created a standardized EMT1 training course. And we started in Geelong with our firemen. And we, again, did the same thing where we would create the floor plan of an ambulance on the floor in the teaching space. We would put chairs for the front. We would put the stretcher in the back. And we would have every action that you would do on your ambulance simulated within the teaching environment. Our firemen did very well. We gave them exams. The majority of them passed. And then we did one intelligent thing. We got a little money for a study to see how compliant they were with their teaching in the real environment. So a nurse would ride in the ambulance and she would document what was at the scene, what should have been done, and what was done. And we were shocked to find about a 10% compliance rate. And we thought, what the heck? So
10%?
yeah, so this was, I was working with Chang Gung at that time, and we published this and about ambulance unmet needs. But Dr. Liao, who kind of was understood, we went to talk to the Geelong fire chief, and he said, well, National Fire Chief hasn't said anything, so I'm not telling my men what to do. So in other words, he hadn't approved it.
Right.
So Dr. Liao had a meeting with the fire chief one Saturday evening where they did a lot of sway and more gambe. And the National Fire Chief the following Monday expressed his support for this change. Compliance went way up. And so we started spreading EMT1 across the island. And then later we moved up to EMT2, maybe like 10 or 20% of your firemen go up to EMT2. And then I think early on, Ma Huiming at NTUH started working with ambulances out of NTUH with ACLS training amongst the paramedics that he trained. So, everything kept going up from there.
Well, that's a great story.
And then I guess the final story in 1998 is when we finally got the Weisan Su to recognize emergency medicine as a primary specialty. And the only thing I would say is before that, when we became TSEM, we actually got Weisan Su to agree to take the EM examination committee and the exam into Weisan Su as opposed to leave it in the society, because there had been a couple of societies where the exam being in the society there'd been problems. So in Canada, we have the Royal College and the College of Family Physicians that are arm's length from any societies. So they're strictly for examination. So we thought that was a better plan.
Then how do you think about
Now,
your son? You're the emergency system now here in Taiwan.
no, I think it's very good. I mean, it suffers from the same problems everywhere else in the world. Like, we're overwhelmed with patients. We have increasing volumes coming in, which is a problem. It's a problem because primary care, community care, is inadequate, under-resourced, underfunded, under-supported, maybe misunderstood by the public. So certainly the emergency department, even though the wait times, it's still the quickest way to get investigations, right? Once you come into emergency, we're a one-stop shop. We assess you, we investigate you, we even arrange consultation for you. Whereas if you go to primary care, often in Canada anyway, you would have to go to another place to get your lab done, somewhere else to get your x-ray done. Wouldn't be the same day. Then you'd have to go back to your doctor to get the results. So Jijin is easier. So that's a problem. The other problem, obviously, is what we call access block. Access block means you can't get the patient out of the emergency into the hospital, right? In Chang Gung, we've had as many as 200 observation beds within the Linko emergency department. Okay, that's 200 patients that shouldn't be there. It's 200 patients that should either be on the ward or like
Go home.
well, yeah, hospital at home, right? That kind of. In Canada, so in my city, the last hospital bed built was 1988, before I came to Taiwan.
Whoa.
And our population has more than doubled. So you're trying to get more than double population, and even more than that, because we're a big referral area, into a bed base that is way too small.
Right.
So over the years, we've done all sorts of things to make sure patients don't get admitted, right? We have IV clinics where if you've got pneumonia or pyelonephritis or bad cellulitis, you go to the IV clinic every 8 hours or every 12 hours, whatever. You have to go and then you go home. And if you get worse, maybe you come into hospital, but we don't admit those kinds of patients. We've got EMTs who go to nursing home, and they will, well, not EMTs, paramedics. They will arrange for x-ray lab, etc., in coordination with an online physician, and where possible, you'll keep the patient there. We have a very strong goals of care program in our province, where patients determine whether or not they should be R1, 2, 3, those are ICU levels. M1, 2, those are medical care levels. C1, 2, those are comfort care levels. So if you're an M2 by your goals of care designation, you almost never transport them to hospital. The C1 you may transport if, for example, even though they're comfort care, but they fracture their hip, there's still benefit in terms of comfort to repair the hip fracture and back out. If you're compassionate care, you definitely don't go anywhere. So one of the ways is to try to limit the number of patients who come to hospital who don't need to be there. Mm-hmm. So that's one thing. But we're desperately short of primary care. We have at least 20% of our patients who have no primary care coverage. So if they come to emergency and we send them out and need follow-up, they're orphans. The only kind of places they can go is mediclinics. But mediclinics are sort of one-off with no follow-up, and they aren't very happy to follow up our emergency patients. So it's a problem. So I'm sure that there's some of these features within the Taiwan environment as well.
Right. And also because under the NHI, it's so affordable. So
right.
Many people, they are probably in the M2 or the C level. They still want to be hospitalized.
Right.
Which make the family care much easy, and they still can go to work. And
right. Yeah, no, I understand that. And that all of our societies and cultures have differences, right. But you have to understand that Taiwan, population has only a relatively short history of understanding Western medicine precepts and concepts. I remember being here in '89 when we would watch television and we only had Mandarin. Mm-hmm. But we could see what was happening, and there was a young lady driving down the road, and she saw a man in the road ahead of her, and she stopped to help. And the ambulance came, took him to the hospital. She went there, and the family said, you must pay. If you were at the scene, you must have been the person who caused the accident. So the idea that Good Samaritan is not a good idea because you'll be blamed. So I think Taiwan, certainly in the cities, has moved on from that. But I suspect even in rural Taiwan, that old thinking still exists. So I don't think that the Taiwan population fully understand the details of the system. Even in Canada, I would say our problem is more everybody expects convenience. Everybody expects instant gratification. Our parents didn't. Our parents were willing to wait. Our parents were willing to suffer. Our parents were willing to follow the system. But today, not so much. And I think that's the 21st century. Yeah.
Okay. Well, thank you. Thank you, Dr.
It's a
Bullard.
great honor. To have you here. And you actually have your name, your Chinese name is actually well known in the TSEM.
Bullard.
Yeah. When I say Bullard, I think all the Taiwanese emergency doctors know. That's him.
Yeah. Thank you again. Be on board and tell us the origin of our society. Yes. Thank you so much.
Thank you very much for having me.
Okay, we'll wave to the audience. Thank you.
Goodbye.
Goodbye.